So welcome to this Usher Institute COVID-19 webinar from the University of Edinburgh. Thank you very much for joining us. My name is Linda Bauld. I'm a professor of public health here at the Usher. And we've got two excellent colleagues joining us today who are going to be speaking around the humanitarian, human rights and global context with a focus on Africa of COVID-19. Now, colleagues who've joined this webinar series before know that Aziz Sheikh, Professor Aziz Sheikh, our director, established this to try and bring together evidence and insights from around the world to inform decisions, to think about research and current and future priorities for colleagues who are joining us from academia, from policy, from practice and other fields. So I know those of you who've joined us before have heard me just give some information about the process, but just bear with me for any new listeners today if you've not encountered this before. So we won't be able to see you as the audience. We've got over 200 people listening on the Zoom and we're live streaming on YouTube at the same time, and that can be used for listen again. So do draw others' attention to the YouTube feed. Please do post your questions, which we'll be considering at the end on the Q&A panel, which you can find at the bottom of your screen, not in the chat box. And at the very end, we'll choose some questions depending on how much time we have. And if you see other colleagues putting a question in there that you particularly want to have covered, please do click on the little thumbs up sign, which you'll see on the left-hand side, and that shows me that people are really interested in that question. So I've mentioned the YouTube. I just want to thank again the Usher comms team, Lorna, Jess and Susan, who've set this up today, and as I say, Aziz Sheikh, who established the series. So I'm really delighted today to be able to introduce our speaker. So those of you who saw the promotion of the webinar will know that today we're joined by Dr. Olatunbosun-Alakija, who has a broad range of experience. She's the former Chief Humanitarian Coordinator from Nigeria. She's also a Global Advisory Board member for WomenLift Health. She's served on the Advisory Board for George Washington University, the Africa Center for Health and Human Security in DC. She's advised governments on the achievement of global goals. And crucially at the moment, she's also advising at multilateral and bilateral level, and that relates to agencies, diplomatic missions, and also donors. So Dr. Ayoade is our main speaker, but I'm also delighted that my colleague, Professor Liz Grant, who's one of the assistant principals of global health at the university, and also, as many of you will know, the director of our Global Health Academy. She also holds a chair in global health and development. So this webinar is a little bit different from the previous ones. We're going to have this as an active conversation between Liz and Ayoade. Dr. Ayoade has a variety of slides she wants to share, but mostly it will be a discussion between my two colleagues. And then, as I say, I'll hand over to you, the delegates, and I'll try and pose the questions that you've posted. So Liz, I will switch my video and my microphone off now, and I'll hand over to you. Thank you.
Thank you. Dr. Alakija, it's a privilege to be in conversation with you today with your particular expertise. And we're going to look at the way that this pandemic that's been moving across the globe in waves is affecting the continent of Africa. Today, where we know there's 1,618 deaths across the continent, and we're very conscious of here in the UK, the number of deaths are recorded at 21,678 today. And obviously there's differences around the measurement, the management of testing. What we know is that the continent of Africa is waiting, and we're not sure how this pandemic is going to impact that continent. And you have insights. And so today, if I can ask you, first of all, can you share with us something around what you're seeing in the way that this pandemic is going to shape countries and where countries are at the minute in Africa?
Thank you very much, Liz, and thank you, Linda, for the wonderful introduction. Africa, as it sits right now, is looking like it will be the next wave of the pandemic. I think there has been around the world a sort of a sense of almost trepidation, some bated breath and concern right from the early days that were this to hit Africa, that the consequences would be truly, truly horrendous. It has come late. And if you look just at the travel patterns around the world and look at flight patterns, even if you look historically at the Great Plague and look historically at the Spanish flu, the timing and the sort of progression of the move of the pandemic is following those patterns. If we go back to how it came through Asia into Italy, for instance, it's very much the same thing, Northern Italy, and from there spread around the world. And we know that in 2018 is when the Spanish flu hit, for instance, Africa, particularly through Nigeria. And over 530,000 people died in 1918 in Nigeria during the Spanish flu. So that provides us with a baseline for this conversation. And the Spanish flu, as the slide says, was a global test of public health, hygiene and sanitation. For this current one, we're looking at a test of health systems, and it really is exposing structural fault lines in governance. If we go to the next slide, I'll talk a bit to the numbers. We can speak to the macro and we can speak to the micro level. What I really wanted to show is we've done a little, myself and a couple of colleagues and partners have done a little sort of plotting of the progression of the disease over the last sort of couple of months since it's emerged. And this particular figure is worrisome. If you look at the progression, and we've allowed for various sort of variables in here, you will see that the USA is currently tracking much steeper than Spain, Italy, Germany, France, and many other countries. On a lower level, you'll see, even though we're hearing horror stories out of Ecuador in terms of their management, because their systems have been totally overwhelmed in every single way, and this is the challenge. The numbers are sort of creeping up, but the slope is not that steep. Brazil also, although that seems to be an upward trajectory. But if I take you to Nigeria, if we look at the trajectory from Nigeria, the curve currently is steeper. The growth is steeper than the USA. And for Africa, that is a major, major concern, because Nigeria, of course, is the largest Black African country. It is Africa's largest economy. We're a nation of approximately, we're told, 180 million to 200 million people. If you're looking at America currently today of about, I think last I saw was about 1,030,000 infected, and almost to date about 62 or so thousand people deaths. That is in a system in a country with health systems that can adapt to this, that can actually handle this. That is in a country where the conversation is around ventilators, and the conversation is around how everybody in California can get a test. But when you start speaking to low middle income countries, you realize that we cannot adapt in the same way. So if we don't contain this, then we're truly looking at a disaster. If we can go to the next slide, please. Very quickly, I mean, this is the main picture was in the previous slide, but this is again the latest from Nigeria, showing in a country where only to date, I think about 11,000 people have been tested out of a population of 200 million. The US again has done, I think, about 4 million tests. The UK, I believe, is in the range of, oh, I forget, you'll know better than I do, but it's in the range of about 500, 600 tests. But we're already seeing this exponential rise. We're also beginning to see, for me, which I think is one of the greater indicators in countries like Africa, and such as it is in Ecuador and Brazil, we're beginning to see huge numbers of unexplained deaths. We're beginning to see, clusters of deaths. And I think one of the things that is beginning to confuse this current pandemic, COVID-19, is because so early on, once it emerged out of China, to the best of our knowledge, once it emerged out of China, there was a test. But whereas in the days of pandemics gone by, and in HIV/AIDS even, for instance, which is my previous experience, what we did was we did a clinical diagnosis. We looked at symptoms. You know, if it walked like a duck, quacked like a duck, then it was a duck. And therefore you took these epidemiological stories, and it was a storytelling. It was true detective work at that stage. Epidemiology was true detective work. Now we're trying to rely purely on science. And that again is one of the points I want to make for low and middle income countries. I want to make for Africa, that we don't have test kits. And so we really can't be reliant purely on the testing that we may have in the past been able to do, but global supply chains do not allow. So for Africa, we have the micro picture and we have the macro picture. All over Africa, yes, South Africa is possibly doing the best in terms of testing at the moment, and possibly started and locked down the earliest. Countries like Nigeria, there are various socioeconomic factors that limit and that temper that ability to react, as well as, of course, the economy. So, I mean, that as a sort of broad overview, Liz, that is where I would start.
Thank you. That exponential rise is frightening, and as you say, it's the unexplained deaths as well, and the struggle to understand what's happening across the whole of Nigeria, that huge country with a huge population, but then what's happening in many other countries. What I'd like to talk about with you is the mitigation strategies that are being put in place at the minute by different countries, and you've been very involved in this. And obviously the World Health Organization has been supporting a number of ministries of health in almost every African country to look at developing early detection mechanisms. But perhaps you could talk about the strategies that you're familiar with and how they're being worked out at present.
Yes, if we could jump down to the mitigation strategy slide, please, get down, please, Susan. Thank you very much. This is the question, you know, sort of with permission from Shakespeare. It really is a Hobson's choice to lock down or not to lock down. That is the question. I mean, of course, in the very early days of the pandemic, what we have all done is copied and pasted strategies from the global south. We, you know, people even in Europe, but there was an attempt to copy and paste what had gone on in China. But unfortunately, governments are different, and the authoritarian regime, for instance, in China, enabled them to lock people in their houses and say you can't leave. And therefore they're a lot more compliant. Also, cultures are very, very different. You know, that has worked out differently in the UK, as we all know. It's worked out differently in Italy, it's worked out differently in Spain. Those are countries, and also in the US, but those are countries with choice. So those are countries where, you know, you can afford to, because the Canadian government, for instance, is paying everybody who stays at home $2,000 a month. They're giving students a stipend of $1,000 or $1,200 a month. The UK government has had amazing sort of measures, financial mitigation measures put in place. The US is struggling to cope with their huge population, but then you get to Africa, you get to low middle income countries. We saw recently India, that just the masses of people who had been told to lock down in a country of 1.3 billion people and told to go home. It simply was not possible. What happens when you don't have a home to go to? We're told to wash your hands regularly and not touch your face. What happens when you don't have running water, when you don't have potable water? What happens when you're living in an urban slum area? So you know, we have copied and pasted, and this is what has happened largely in Africa to date, that there's been a copy and pasting of these mitigation, you know, strategies, lockdown. That was the first word we heard. But perhaps we should have paused a moment and looked at our own local context. We need localized strategies for local situations. And yes, whilst we must stay physically apart, a lot of people in the countries where there's been high mortality, for instance, Italy, for instance, multi-generational households, people living in crowded conditions, in small apartments, in mega cities, for instance, such as Lagos and you know, Kenya, in Nairobi in Kenya, South Africa, people who are living in Soweto. How do they lock down? And whilst I mean, I'll speak to Nigeria specifically. In the last 4 weeks, there has been a lockdown in the major cities of Lagos, Abuja, and a neighboring sort of city that borders with Lagos, or a state of Ogun State. To my mind, it has not been effective. It has not been effective because people have not been able to. People live not only in a gig economy. I mean, in the Western world, you can say we have a gig economy, but in parts of Africa, it's a subsistence. It's a day-to-day. If I do not hawk that, you know, bottle of water on the side of the road, I don't have my next meal. I cannot feed my child. And so we're starting to hear from people, and there's very angry sort of messages coming out in videos, people saying that I'm going to die of hunger before I die of coronavirus, of COVID. There's a lack of belief as well. Go ahead, Liz.
No, you've just touched on that issue, that some of the unintended consequences of these strategies that could be horrendous. Many people are asking, are the effects of the strategies going to be worse than the disease itself? And you're beginning to give us a flavour of that. So yes, continue on in what you were describing there in Nigeria.
Well, I mean, for me, this is about proffering solutions, and it's not a critique in any way. I mean, I think really this virus is so new, it's hit all of us completely. Yes, we've thought about it for years. Those of us who are public health professionals were always waiting for the next pandemic. But, you know, it's like everything, you sort of think it's never going to happen. Well, it could. It's sort of ethereal in the future, but here it is. And what are the local solutions? How do we physically distance whilst, or socially distance, or physically distance, whatever you want to call it, whilst also maintaining people's lives and livelihoods? Because what we have now is the battle between lives and livelihoods. And there are some countries and some cultures that are actually beginning to say that, well, you know, if people die, they die. It's horrific to think about. But we are being faced with this Hobson's choice, this impossible choice to make at the moment, that do we open up our economies and allow people to basically, you know, continue to live their daily lives and to have their livelihoods. I mean, of course, whilst keeping certain things closed, you know, keeping schools closed, making sure that you provide the very basics of the social safety net. But again, back to the low middle income countries as a whole, the World Bank and the IMF are all coming up with huge packages, palliative packages at the moment, because these countries don't have the ability to provide those safety nets. There is only so much food that you can hand out in communities of you know, 200,000, 500,000 people. There is no cash to hand out. The money needs to circulate within the economy. So how do we keep our livelihoods and economies going whilst ensuring that we protect lives? Public health systems need to be strengthened, but we don't have time to strengthen those public health systems. So perhaps instead of, you know, isolating everybody in sort of the entire country and locality, what we should have done, and for countries that are coming behind, for instance, for me, one of the solutions would be to identify quickly. It's that early detection and treatment, you know, for the clinicians amongst us. Identify quickly, you know, for instance, Fiji, which is my other home, in New Zealand, who have done an incredible job with this, identified clusters of cases. They locked down those localities. They did mass testing within those localities whilst allowing them to continue with their livelihoods in those locked down areas, but setting up fever clinics and testing, mass testing everybody. But the rest of the country and the rest of the economy was allowed to progress. And I think perhaps those are some of the strategies that were local to the population that we need to begin to look at in more of the low middle income countries, because we can't simply just lock down, but we also can't not lock down. But we need to pair lockdown, a sort of a tailored, localized lockdown, with testing and with appropriate mass communication, sort of BCC, behavior change and communications campaigns to ensure that the message is truly getting out there.
I think that's so valuable, and you've really sort of layered out this importance of the balance that we need to be managing at the minute. Before we move off this just one theme, can I ask about actually the word lockdown and how it's interpreted among different communities that you're working with? Because it's a political word. It's a word that has very strong connotations that are associated with fear. How's lockdown, that word, being seen?
Well, I mean, that's brilliant. You know, so for instance, you'd have, in the early days, even in America, they argued about shelter in place, because what shelter in place actually means is that if you have an active shooter situation, you know, you should stay in your room and get under a table. But then that was being used inappropriately. Lockdown also, I agree. I mean, what does that mean? For those who are resistant to authority, you tell somebody to lock down, like me, you know, immediately, first thing I want to do is go outside, because, you know, why am I locking down? What? And then it also brings up certain fears, you know, of you know, in America, again, in the early days of this, we heard that in addition to people going nuts over buying incredible amounts of toilet paper, they were also buying guns because of the fear of lockdown. So, I mean, as I said, we have done a complete copy and paste of global sort of North solutions to my mind, in the global South. I think we need to look at more containment words. We need to look at more community sharing, community togetherness, but words that go to our culture, that go to who we are as a people, as we plan those behavior change campaigns, because that is what we need to do from now on. The new normal, there is no normal anymore, so we need to create this new world that we're going into, and that world cannot include, you know, we're locking down for the next 6 months when the next wave of this comes, as it inevitably will, probably in another few months' time. Very quickly, my thinking actually with Africa is that we're not going to see the sort of U or V or W, whichever one you want to call it, where we have these peaks and troughs. I more think we're going to have sort of more of a sustained line for a while. Because if we don't get it right now, and unfortunately, I think we are missing it, if we don't get it right now, then the mobility of our populations, I mean, we're a continent that's built on cultures that are so interconnected and interrelated. And whilst we have borders and we have lines, we don't really, I have a lot in common with people from Ghana, of the Tree tribe, for instance, and some people from northern Nigeria have more in common with people from Chad or Niger than they do with somebody from Lagos. We're all one people with very fluid borders. And so that poses its own set of challenges for policymakers.
That's very interesting. And you alluded to the issues of violence. And maybe I can ask you more about the concern globally that the isolation and the encouragement people to be at home has raised the level of gender violence and domestic violence in the home. Could you say a little bit about the situation as you're seeing it, and also, again, your insights and thoughts as to how we could tackle this rising rate of violence?
Yeah, the unintended consequences, if I can get Susan to move us to that slide just very quickly. I mean, there are several sort of, you know, other consequences to COVID-19. It's further up, as it were. Yeah. You know, so you have the obvious health, but then when you go to social and societal, obviously there are people who are locked in houses together who would not normally be. There are people who've been managing relationships for years who are now stuck together in the same house as a frustration of job loss. And we are seeing a huge increase in gender-based violence. You know, I mean, there are deaths, unfortunately, children are being harmed. again, it speaks to, for me, this localized solutions and understanding, because in Western cultures, say for instance the UK, you know, where you live, where we're seeing people who, not just seeing, but where you know, there's hotlines and there's help available. It's going on, but at least you know that there's an out. For instance, some governments I know have actually said, look, if you're stuck in a home with a violent partner, we will rehome you, we will rehouse you. And that is not happening in many of the low middle income countries. It can't. And then you can't leave your house, you can't run away. I mean, typically people would run out maybe into the street and the community might help them. They're screaming, they're shouting, but now there's a fear and people are stuck together. These are some of the really heartbreaking things going on that, you know, for those women, largely, predominantly women, you would say that because gender-based violence, of course, does not just, you know, affect women, but it's predominantly women, you know, you would typically say, they would typically say, I would rather catch this thing. I would rather be out. I'd rather get COVID and be affected by whatever the health consequences are than stay in this situation that I'm in. So I'd rather fear that, you know, once this is done, we're going to see a real reshaping of society in many ways. I mean, we're already hearing the stories out of China, which, because of course they've now gone through one cycle of this, where divorce rates have spiked by about 30% in some regions, Wuhan particularly, because people lived in houses with their partners, their husbands, particular wives, and couldn't leave for 2.5 months, and suddenly decided, oh, I don't think I like you, because, you know, they were distracted previously. So the societal effects are huge. I mean, I also want to talk about children.
Yeah.
I was just before this of another webinar with the Vice Chancellor of Cambridge University, who's talking about school and how people are going to return to universities. But, you know, then you talk about the littlies, you talk about the 7-year-olds and the 8-year-olds. And again, in places like Africa, where Zoom learning is not really compatible with countries where you have broken systems, you have no infrastructure, you have no electricity. How are you going to teach them? There's some innovation in radio, but even that is a novelty, you know. How are you going to teach these children? And how are they going to catch up? We're going to have a generation in about 10 years' time who, to my mind, might have lost an entire year of that foundational education. So these are some of the consequences that are beginning to emerge in sort of low and middle income settings.
I think that's so powerful. You're saying that sense that people will have or children will have lost some of the fundamental building blocks of their education. And obviously the risk is that girls will be losing those fundamental building blocks even more so than boys when they go back, because girls are already excluded so much out of the education system. And I think across the world we need to think about what the new normal, what post-COVID will look like, and how we can ensure that some of the messages that have been coming out of COVID, as to say, these unintended consequences that we can see, how they can be changed and a new form developed. You are an advisor for a number of bilateral and international, multilateral institutions. I wonder, can you share, I mean, obviously not breaching confidentiality, but can you share with us just some of the questions that you're being asked that give insight into how organisations are seeing and understanding the impact of this pandemic on themselves?
I think largely most sort of multilaterals and sort of bilaterals, donors and organizations are looking at the day after. They're looking at tomorrow. We're looking at post-COVID. You know, right now we have the massive impact of the health crisis that we have on our hands. But COVID is not just coronavirus, and COVID-19, you know, is not just a health crisis. It is multidimensional, it is multi-sectoral, and we need to approach it as such. You know, so from the health perspective, again, if I, you know, use the Africa example, sadly, it is almost, this is difficult to say, but it's almost useless to try and think of the health mitigation in terms of with those with severe illness because of the with comorbidities or what have you, because it is almost impossible in most of our settings, unless somebody presents with a mild to moderate, very moderate illness, it is almost impossible to provide the treatment that is needed. You know, the arguments around ventilators and you know, the various treatments that are being had in the Western world just don't apply, because ventilators are a distraction in an African setting. I mean, for most certainly somewhere like Nigeria, because it's not about whether you can afford to buy it, it's whether you have the electrical capacity to deal with it on a daily basis, because we have power generation issues. It's whether you have the technical capacity because of the brain drain. And I mean, many of our doctors all across most of Africa have left, most of our specialists. So you don't have the intensive care specialists, you don't have the, you know, physiotherapy nurses who would typically look after patients in settings like that. So COVID-19 becomes, within, you know, the African context, in sub-Saharan Africa for sure, becomes something that you have to really you have to almost close your eyes to the, well, how do we treat patients? And you have to begin to say that, well, how do we mitigate the effects thereafter? How do we save lives thereafter? These unintended consequences that you're talking about. So most people are looking at tomorrow, whilst right now we're trying to amp up, you know, testing and trying to find some containment of sorts. But as it gets out of control, which it clearly is doing in many countries, I think the internationals and the bilaterals are beginning to say, well, what do we do tomorrow? You know, once this is over and these economies have been so shaken. I mean, look at the price of oil has brought Nigeria largely to her knees. The price of oil last week was at minus 23 or something ridiculous. Brent crude, which is what we rely on, and our particular sort of oil export, I think was at about $11 to $12 per barrel, where it was about 70 just 6-7 weeks ago. So the economies are crashing. I think very much people are looking at the economy at the moment and looking at how do we shore that up, because to rebuild our health systems and to build back better our health systems at the primary care level as well, we're going to need to have a strong economy. And primary care now becomes even more critical, because it is only primary care, it is only that UHC, universal health coverage, that is able to ensure that when the next wave of this comes along, that our communities have the capacity and are strengthened enough at the basic level to be able to at least maintain those patients that they have. One thing I want to mention also very quickly is the fact that we're facing famine now in Africa. You know, the World Food Programme has been very vocal about this, that we have over 200 million people, that food security is going to become a major issue. You know, we have competing crises, as I'm sure you know from your work in Uganda, with the locust invasion, but also now we have people who can't go to their farms. So if you say lockdown, and you can't move between boundaries, how do I go to farm and how do I get my little crop, which is what feeds my family? And maybe, you know, in trading, I'm able to feed others around my local community. So it's the economic, it's the societal. And then in terms of political, we're also looking very strongly at making sure that countries don't just fall apart. We're beginning to see state failure in Lebanon. We're beginning to see state failure in many countries around the world, because the societal bonds of trust with government and that social contract seems to be broken. And people, we were held together very sort of loosely by some connective tissue. You know, perhaps it was that physical being close together, but now that we're distancing, our trust is completely broken in our systems. And I rather fear this is going to cause regime change around the world, not just in Africa, but largely in the low middle income settings.
That's a very frightening prospect that you're describing, and in the way that society is losing its trust, and in the dysfunctionality that we have seen as health systems retract and retreat because of the pressure they're being put under with COVID. But I'd like to explore with you two things, and one is around primary health care. As you've identified, we need to invest in primary health care. And are you hearing from colleagues across the different African nations situations where primary health care is actually doing a tremendous care, providing tremendous care, or are you hearing situations where primary health care is collapsing? What's the sense that you're hearing?
Primary healthcare is collapsing. When you have weakened health systems, in countries where you have weak health systems, there's been an over-reliance on the tertiary structure. There's been an over-reliance. There's also the, rural-urban drift, these hugely urbanized societies and communities. Infrastructure, roads, etc., are so poor anyway that, again, back to our unintended consequences, a woman was more likely to die in a rural area even before COVID than she was if she was in an urban area, because it could take her 7 hours to get from where she is to the nearest health center because the roads are so poor. A child who's born with distress, fetal distress or respiratory distress at birth is more likely to die. So we already know that those centers have been neglected. And again, because of the brain drain, the drift of people into urban areas. I mean, certain parts of Nigeria, we heard last week that 70% of the doctors have left the medical posts because they've got no PPE. So even though they've heard there's a pandemic and they've heard there's COVID-19, the weakness of the health structure, the weak governance structure means, and this social contract and this trust that I'm talking about means that they have no confidence in a system to stay because they know that this is a sure death sentence. So primary healthcare is broken. That system is broken across several countries. And one of the lessons for me that we must learn out of this is that it needs to be rebuilt. We need to go back to the community. We need to educate at community level, but we also need to make sure that PPE and basic sort of materials and commodities are available at community level. And we need to invest in training, not just of, surgeons and obstetricians, but we need to invest in community health worker training so that we have an army of those at community level. Countries like Ethiopia have done an amazing job with that, an army of community health workers who can go around the community. I mean, their spread, it doesn't seem to be so bad, and I can tell you why. Because they have, women out there who are also, they're spraying, they're the ones who are doing the malaria spraying for mosquitoes, etc. And they are ensuring that everybody, house to house, the education is going around, making sure that people know what to do, what not to do. So we're not relying on rumor and hearsay and there's a weird disease out there and 100 people died last week. No, we have facts. We need data. Data is absolutely critical.
Yes, that is so important. And you've, by using the Ethiopian example, which I think is really powerful around how Ethiopian community health workers, particularly, but right across the Ethiopian health worker system, have been promoting healthy messages. Can I ask, what other lessons, as it were, can we learn from different African countries' positioning around their strategies for managing COVID, and then their push forward in thinking about what a post-COVID world will look like for them? Are there lessons? I mean, we've seen already simplified triage strategies coming out, very proactive screening, hand washing facilities put at bus stations, put in schools, put in transport hubs. I was very struck when I was flying into Rwanda just before flights were stopped, that Rwanda, at the airport, my temperature was taken. I was asked a quick series of questions. Everyone was. In the UK, we were not doing that. But what lessons do you see that we should be listening to as a global connected world?
Well, we need practical, workable solutions. We need to move away from the high-tech, highfalutin, you know, I mean, I read somewhere yesterday that the US has offered to send 200 ventilators to Nigeria, and I chuckled and said to a colleague of mine who works in international health, you know, I said that, well, you know, you plug one of those ventilators into some villages and the local grid, power grid will go down. It makes no sense. I mean, we need local practical solutions. We need, just like you said, Rwanda did an incredible job with their foot pump hand washing stations at bus stops, for instance. You know, yes, we're also learning every day about this virus. So in the early days, Nigeria also did amazingly with making sure, because we learned lessons from Ebola. You know, and Africa has learned lessons from Ebola. We've learned lessons from HIV/AIDS. So we had temperature checks at airports, but then we're finding out that most people are asymptomatic and temperature is not really telling us anything. So I think as the disease itself, as the virus itself has evolved, we're also seeing that it is behaving differently in different populations. It is catching us all off guard. And I think Africa has been evolving also to that. The messaging is beginning to come out. You know, we've been so focused on containment so far, but we need to now going to have to move to that next step of saying, how can we be practical about this? How can we ensure that we not just, you know, take care and make sure that people who are dying die with dignity, and that those who are, you know, that we're able to bury with dignity, and that families are cared for in this horrible situation, because that is the reality that we're facing. You know, we can be as scientific about it as we want, but the reality is that people will die, because we're seeing it all over the world, and we can't brush over that. But we also have to, so we need to incorporate our culture into that. In the early days of AIDS, for instance, I remember how they changed the whole funeral practices and widow inheritance practices in Southern Africa. You know, when somebody would die, and they were realizing that this was actually spreading the disease further. We need to go back to those lessons that we learned in those days. There was a lot of community mobilization. There was fear, but then there was community mobilization because there was information. There was information, there was data, and there was a sense of the collective good. I think one of the most difficult things for me about COVID-19 is we're not able to get together. So there's this sense of, you know, it is our very collective togetherness which will help us to end this, but we're forced to be apart. There you are, you know, in a room on Zoom, I'm in a room on Zoom, and we can't put our heads together literally with a cup of coffee and go, oh my goodness, Liz, what are we going to do about this? And scribble things on bits of paper. So we're going to have to get creative about that in the long term. But I think our local African and other cultures, India and South America, there are remedies for this that we can pull together. We can stop copying what's going on in the West, because we can't afford it. There is no amount of money that you're going to throw at high-tech solutions that is going to help, because you will also then need to train the people to adapt to this. We need to test. We need to contain. We need to isolate those who are infected, and we need to then begin to plan for tomorrow.
Yeah, and you're right. There are brilliant scientists across every country in Africa. What would you say would be the way to ensure that their voices are heard in the global, you know, discussion around what next?
I think, first of all, I mean, because of course it started in China, and then it's gone to the West, and Africa and many of the low middle income countries have been caught on the back foot. I think the voices are not being heard enough. I mean, I know of a wonderful young woman in Nigeria, Temi Giwa-Tubosun, who, you know, set up the first drive-through testing center, very, very low tech, very low cost in Lagos, Nigeria, which, you know, that is the sort of way to go. And there are many things like that beginning to come up. I think because we're hung up on ventilators, a lot of people are spending time and energy trying to make mini ventilators, which again is a waste of time. We need to more think of, you know, how do we provide community solutions rather than individual solutions. I think pulling out those voices and encouraging those voices to be more to be more vocal about whatever it is they're doing in their local communities. Again, back to the lessons learned from HIV/AIDS, we talked about affected communities. You know, we got to the point where we wouldn't move forward unless we had somebody working. I was part of the initial setup of UNAIDS in the Pacific. And, you know, the big thing there was a lot of stigma around this. But once we started to get people who were affected, you could hear their voice. And so if I'm in a meeting at the G20 or G7, or somebody from, you know, whatever country in Africa is invited to present at the G7, you will stop talking about the need to produce 50,000 ventilators, because I can tell you that, well, that's not going to work for me. And what's going to work for me is pedal hand washing solutions at bus stops. What's going to work for me is mobile test kit clinics. What's going to work for me is ensuring that the regular immunizations for children, because that's the other part of this, the regular immunizations for children are not forgotten, that maternal and child health goes on, and that we don't forget the other malaria. We have a probability of losing double the number of people to malaria this year because people just aren't presenting at healthcare facilities. You and I had a conversation about this just yesterday, which was personal. You know, I felt unwell. There was no way on earth I was about to go to a hospital, because, you know, you go in with one thing, you come out with another. So how do we help countries where the health systems are already struggling, where the economies are already struggling, where the trust is already broken? How do we help them move on to that next phase? And this is where not just scientists, but economists and the private sector need to be brought to the fore from the low and middle income countries.
That's a hugely important point about the collective nature of the solutions. There is no single solution. This needs everyone. And as you say, so many countries learning the lessons from the HIV pandemic and from Ebola understood very much around how collective community matters to reduce stigma, and how also communities supporting the young people who are so much of the future, ensuring that they get education, they get support, they are able to have a voice to take things forward. I'm very conscious our time is up, and a number of people have been asking questions, which I'd love you to have a chance to respond to. So can I hand across to Linda for some questions? Is that okay, Linda?
Yes, thank you very much, Dr. Alakija, and also Professor Grant, because I think that was a fantastic conversation between the two of you. So sorry to butt in there, but as I've been following the questions, we've had a huge number of questions. So I'm just going to choose a few here from the most popular. And what I wanted to start with was a question, Ayoade, about demographic differences. Now, just looking ahead, how do you think they might play out given the susceptibility of older people and also the much younger demographic that we have in many African countries? Does that mean there's going to be a lesser burden, or will there be, you know, big consequences as a result of those differences?
Thanks, Linda. That's the big one. We're hearing, I think I started to say earlier, this virus is behaving differently in different communities. We're beginning to hear already, also the research and the evidence is telling us that there's been mutations, and even since, you know, we're hearing that there's about 30 mutations so far. So, you know, the Lombardy region sort of outbreak seems to be different, for instance, to the Germany outbreak and what have you. And to my mind, we don't have the science behind it yet. We don't have the evidence, and I very much prefer to be evidence-based. But to what I'm seeing anecdotally at the moment, it is also behaving differently in Africa. You know, I mentioned in conversation with a colleague just yesterday that this thing seems to be dropping in age range. So the initial thinking around Africa and many of our sort of other low middle income countries was that because, you know, the demographic we're such a young population that it wouldn't affect us so badly. Number one, I think we made a mistake as a global health community at the very beginning of this, when we pushed the messaging that this was a disease for the elderly and the infirm. because we did not know enough about it. And I think that caused some certain amounts of complacency among certain populations. I certainly know that in Africa, many people were like, oh, well, you know, how many 80-odd-year-olds do we have anyway? It's not going to affect us. Then there were the myths around TB vaccinations and BCG, that if you've had BCG vaccination, then in a country, in a population with BCG, it was less likely to hit. And then, of course, we had the misinformation campaign around hydroxychloroquine, which again was incredibly difficult for Africa, because people again felt, well, we've had malaria, we take chloroquine all the time. I mean, some people died. I know in Nigeria, a few people actually took overdoses of hydroxychloroquine and actually died. So that there's almost a perfect trifecta there of you know, lack of evidence, that people are sort of saying, well, demographic, chloroquine, TB vaccination. The truth is, what we don't know about coronavirus is more than what we do know. And I don't think at this moment that the lower demographic age of these populations is actually that much of a factor, because our other comorbidities are probably overcorrect for that. You know, diabetes and high blood pressure. I mean, I tweeted yesterday about a certain African country where I said that, you know, Nigeria in itself is a comorbidity, because the stress of life, especially particularly in the megacities like Lagos and Kano, the stresses and strains of life that people can't imagine anywhere else are in themselves a comorbidity. So I think we have demographic young, yes, we have a mutating virus, we have a virus that is behaving differently that we don't understand, and we also most certainly, you know, have huge comorbidities and huge factors in the low middle income countries that I think are in Lagos. I think the average age is about 45, 50. Mortality, we're sort of in about 50. So I mean, I think our life expectancy is only 53.6 or something anyway. So we're sort of pretty much there or lower than that. So to me, I would say COVID is hitting you where your life expectancy is at.
So just to build on that answer, you talked very eloquently earlier about domestic violence and the consequences of that. We had a question around mental health more generally. How much discussion has there been in Nigeria and other African countries about the mental health consequences, both for healthcare professionals, but also for families who are, you know, experiencing the imposition of lockdown and other restrictions? Is that an active source of discussion, and what do you think we could do about that in the global South?
Very little. I mean, I know that I think we're in the acute phase of this. You know, we're in very much the emergency phase of this. And again, you know, you mentioned Humanitarian, which is some of the work I've done in the past. You know, when you're in a immediate humanitarian situation, the niceties almost get forgotten because you're desperately just trying to put out the fire. You know, it is only, I say often, it's only when, if your house is on fire, you have to put out the fire before you can do the renovations on it. And unfortunately, right now, you know, even if you were in the middle of a major renovation work, you can't dress it, you can't furnish bits of it whilst the house is on fire. And right now that these houses are on fire, you know, the entire world feels like it's on fire. There is some work going on. There's a few little, particularly in Nigeria, I believe there's a group called Mentally Aware that are trying to do a little bit of work around, you know, but this again is in small, I mean, Lagos, in urban centers that are trying to help with people dealing with domestic and gender-based violence. I know that there's been potentially an upsurge in rapes, for instance, and there's a wonderful young lady called who won the Commonwealth Award last year, who has an organization called Stop Rape, and they're trying to do some work around that. But it is difficult to do that, because what do you do when you come across somebody who's been so affected? You go, you meet with them, you hug them, you talk to them, and it's very difficult to have that over Zoom. Is a luxury. You know, one of the things I say is that social distancing itself is a privilege. Your social distancing, you know, is a total privilege, and it is not my reality in many instances. So I think this acute phase, it's difficult to deal with many of those things, but we must keep them at the back of our mind, and we must keep up the advocacy and connect with people such as yourselves and groups around the world who will help us to keep it on the front burner.
So I'm going to ask two final questions together, and then I'll just hand over back to you and Liz for any concluding remarks. The two, I'm sorry, colleagues, that I can't answer all or can't ask all these questions, but we will send these on. Are you seeing any pivoting from the global philanthropists, Gates, Bloomberg, etc., towards addressing this situation and particularly the longer term consequences? That's the first question. And secondly, what would you regard as the priorities for thinking about what the UK and other countries could do to support countries in Africa when we come through the peak? For example, should we be prioritizing sending antigen and antibody testing to other countries and sharing those kinds of approaches? So those are the two questions, global philanthropists and priorities for perhaps testing or other things we can do to support a range of countries.
Excellent. Those work very well together. I'm conscious that I have 4 minutes. I'm going to be very quick. First of all, global philanthropist. I think, the role of Gates and Bill and Melinda Gates Foundation has been very clear. They've been talking about this for years. And they, of course, as you know, have now committed to building, following the vaccine development through all the sort of stages to ensure that we accelerate the development of the vaccine. So I think definitely we're seeing global philanthropists pivot. We're also seeing local philanthropists, I must say, in Africa. We're seeing, at the community level, we're seeing church groups come together to go feed people. So we're beginning to see a lot of that. We're seeing, some of our billionaires within Africa and Nigeria in particular, beginning to come together and put funds together to try and purchase the supplies, but the global supply chains are broken. So in the initial instance, they were all trying to buy ventilators and what have you. And what the world is beginning to understand right now is that we need, and I'm going to link these questions, the answers as well. We need to link both the philanthropists, the private philanthropists, together with the multilaterals and the bilaterals. We need a lot of soft diplomacy. Soft diplomacy is a huge part of what I do and have done in the last few years. But we need soft diplomacy to ensure that, yes, a philanthropist has 2 billion, naira or $500 million, and they want to provide test kits, but you can't actually buy them, because there aren't anymore. We don't have the bargaining power. We don't have the negotiating and bargaining power. Some of these smaller nations, perhaps Nigeria has more than most, but some of the, you talk about Burkina Faso, which is actually experiencing one of the worst outbreaks in Africa at the moment. They don't have the bargaining power to be able to purchase those test kits so that they don't get grabbed off a plane somewhere mid-air by a much bigger nation. And so what we need to see is more of a convergence of the private sector. I talk a lot about the nexus in my humanitarian work, but we do need a nexus here again. We need one between the philanthropists and the bilaterals, the multilaterals, and the governments. We all need to be speaking the same language. You talk about UK aid and how can the UK and others begin to help and work. And I do know, because as you're aware, that I do, I have quite a bit of contact and conversations with both the UK, the US, and also some of the Asian, Korean aid have really reached out, the international financial institutions. Everybody is saying, what can we do? Right now, there is too much going on at sort of national level for there to be enough attention to be paid to that sort of coming together but I think there needs to be an aggregation. There needs to be an aggregation of support from the internationals and the multilaterals, and there needs to be an aggregation of the ask from the low middle income countries, because our asks will be similar. Nigeria, for instance, you mentioned test kits and what have you. Nigeria, for instance, is desperately in need. We've done 11,000, perhaps 12,000 tests as of today. We're desperately in need of test kits. But beyond that, what does tomorrow look like, Linda? Once this is over, to my mind, before you can get on a plane and travel to any country, you will need to be able to prove, to most countries, you will need to be able to prove either that you have antibodies to this, or that you have been tested, you're not sick, or that there's a vaccine. I think we're not looking that far ahead, and I think that this is where that question, the philanthropists, what Gates and people like that are saying at the moment is that they will prioritize making the vaccines available at low cost to the low and middle income countries. And I think that is our biggest advocacy point at the moment. Just again, back to the HIV days where we advocated for the drugs to be made available to Africa and they weren't for the longest time. We need to, from the get-go, advocate the vaccines, once they're available, are accessible widely, again, through that universal healthcare, primary health network that Liz and I talked about earlier. There is no time to waste. We need to move now.
Well, I think that's a very appropriate point to end on, and I'm sorry that we do have to close now, but I think that was a brilliant discussion between the two of you. I'd like to thank you both sincerely very much. And just bear with me for one more minute for those still on the webinar while I just say a few words about our future events. So we have 3 confirmed future webinars. And next week, we'll be hearing from Professor Igor Rudan, our own professor from the University of Edinburgh, who is the special advisor to the Croatian government, and particularly at the moment actively helping them plan for the release of some lockdown measures, not only in Croatia, but in neighboring countries. And that's on the 7th of May. It'll either be at 12 noon or 2 p.m. We'll confirm that ASAP. The next week, I'm really delighted that we hear from Dr. Tai from the National Institute of Hygiene and Epidemiology in Vietnam. Most colleagues will be aware that Vietnam has been very successful to date, has a very small number of cases. And then a little bit different, the following week, May the 21st, some of you will have picked up from the press the controversy around COVID and tobacco and smoking. Is it protective? What's the role of nicotine? But crucially, we'll begin to move into the issue, which I think is of interest to many colleagues, and Ayoade has in fact touched on it herself, as has Liz. How do we reconcile the need to focus on a non-communicable disease response in the face of a communicable disease pandemic? Big challenges for global health systems. So hopefully that webinar will begin to get into those topics. So that's 3 more, and then I'm in active discussion with other colleagues from a range of countries. So we'll keep running the series throughout May and into June. So thank you very much again to both our speakers. The slides will be available as a PDF. And I'm sure that both our speakers would be happy to engage by email around future discussion and further questions that you have. So thank you very much to everybody. I'll say goodbye.
Thank you, Linda. Thank you. Thanks, Liz.